So, in the medical world, they're known as crisis standards of care, and they're intended to be used only if and when patient needs caused by a major catastrophe or a pandemic, such as what we're in now, outstrip the resources available to adequately provide care to everyone, especially at critical junctures. As with a lot of other things the past few months, COVID-19 has pulled back the curtain on healthcare issues many of us never thought we'd have to think about or worry about. And even those so-called worst-case scenarios now planned for may not quite unfold, crisis policies are being issued, surfaced, talked about just in case, and they're being challenged in many instances for, among other reasons, failing to account for fundamental health and societal inequities. So, what have been the driving ideas behind crisis standards of care, and how might they evolve to promote equity and to gain greater trust and acceptance during really dire times? So, that's our focus for this fourth in IHI series of free virtual learning hours devoted to COVID-19. The we for our series includes two regulars at my virtual side, IHI President Emeritus and Senior Fellow Don Berwick, and IHI President and CEO Derek Feely. And our special guests today are Dr. Christine Kessel. She's Professor of Medicine at UCSF School of Medicine, and Dan Henfling, a Vice President and Technical Staff at InQtel, and he's a co-chair of Crisis Standards of Care Committees that have taken place over the years, issued by the Institute of Medicine, now known as the National Academy of Medicine's part of NASM, Academy of Science and Engineering and Medicine. So hello to all the panelists. Hello to everyone joining us. You're going to hear from this panel for about the next half hour, and then we're going to turn to Q&A and discussion. You can chat at any time, your thoughts for the panel, for one another. Be sure to chat to all participants so everyone can see what's on your mind. Don, we start with you, Don Berwick. Crisis standards of care seem necessary, and really everyone hopes we never have to use them. The likelihood of furthering health inequities, as I've mentioned, is one huge concern, also concerns about rationing. So talk about this dilemma of something that perhaps needs to be there, and yet we would rather kind of, put it back in the drawer. What's that meant maybe historically and in this context now? Thanks, Don.
Thank you, Madge. Thank you all for joining us, and especially to Dan and Chris, friends and scholars whom I deeply admire. I could not think of two people I'd rather have conversing about this important topic with us. I should say that, at each of these virtual learning hours, we have ended with a poll of topics that the attendees want to hear about. And this one, I think, has been at the top of the list, either number one or number two every single time. So there's a tremendous amount of interest here. The idea of adjusting standards to crises is a dramatic one that is, as you said, Madge, it's not one we welcome dealing with, but everyone kind of feels the looming presence of this threat that we may, even in a wealthy country, especially under crisis circumstances, we may come short on resources and have to make very, very difficult decisions about who to help with what resources. People want guidance on that. This is not a new topic, though, at all. As both of our guests know, because they've been part of the history, the exploration of the ethics behind decisions that are made in medicine is now longstanding. It's decades, if not more long, with some tremendously interesting thinking about it and applications, because a lot of hospitals maintain ethics services and have tried to harness the knowledge. It becomes particularly dramatic in this episode. As you said, Dan Henfling co-chairs the subcommittee, serves on the new National Academies of Sciences, Engineering, and Medicine Standing Committee on preparedness for emerging infections and 21st century health threats. He has co-chaired a subcommittee that issued a report on this topic, which he will, of course, be referring to. And we appear to need guidance like that. It is not without controversy, and we're going to get into some of that controversy here. It's important in the COVID era. It's important all the time. And I think we're going to be learning a lot in this era about maybe perhaps new ways to think about the standards we have. I want to say that I personally view this as not one, but two categories. And I don't know if our guests are going to want to get into it, but there is the dramatic form of it. We run out of respirators. Who gets a respirator? And that is the most evident, and it's the one that attracts. It's the lightning rod question. I think there's another version of this that maybe Chris and Dan will want to comment on, it's more subtle than that. But like under crisis circumstances, a lot of things have to flex in healthcare. Decision rules about when we try out a new medicine, for example, as people feel the pressure. We're seeing that over and over again in the COVID discussions. Decision rules about what rules and regulations have to be maintained and which have to be relaxed. One example of that we heard about in the conversation with our friends in London at a prior learning hour, where they're standing up, a 2,000 bed intensive care unit in the convention center, the Excel Convention Center. That's happening in other cities around the United States as well. Well, you can't take the standard rules about space allocation and staffing and equipment right into those spaces. They don't fit. You have to flex the rules. That's a crisis standards issue to me. So is job rules. Who gets to do what? As we run out of personnel, we have to have people do things that they may not be trained for in the classical way. What do we do with that kind of idea? That's a short list of what I'll call small c crisis standards of care that maybe Dan and Chris would refer to. Into this realm, as we'll talk about, the other issue that's entered absolutely crossing with the issues of standards is equity, because we now are in a deeply unfair society where people of disadvantage are being left out. How do we think about that? Because an absolutely colorblind or wealth blind policy may actually be not what we want in an era when injustice is so pervasive. So we've got a lot of terrain ahead. I've talked far too long. Let me stop and let the experts take over. Madge, and thank you so much for the chance to frame this a little bit.
Thank you so much, Don. All right, let's get into some of the circumstances and also this interesting report that prompted our opportunity, I think, to look into this, because I think the National Academies in many ways is the closest thing we have in medicine and healthcare as a kind of countrywide set of principles. Dan Henfling, welcome. He has the inauspicious, challenge of trying to get through a fair amount of substance in a short amount of time. Please take advantage of the link so you can peruse either now or afterwards. Welcome, Dan, and you've got the floor. Thank you.
Great. Thanks very much, Madge and Don and Derek. It's wonderful to be here, Chris. Indeed, it will be very hard to summarize a decade's worth of work in 7 minutes. And so I really do encourage you to take a look at the significant body of literature that we've published over the years on this topic. And so really what I want to try to emphasize in these few minutes is that unlike the president's comments about who could have imagined an event as cataclysmic as this, we have been thinking about this for quite a while. And indeed, under the auspices of the National Academy of Medicine, originally the Institute of Medicine, we developed a framework for catastrophic disaster response, specifically for large-scale public health emergencies. And we began that a decade ago, in between the first and second wave of the H1N1 pandemic, which, as we know, was really no more than a glancing blow here in the United States. And we answered the questions of, at the time, the Assistant Secretary for Preparedness and Response, Dr. Nikki Lurie, who posed to the National Academies the three following questions. Who should receive care when not all patients can receive care in a catastrophic event? How should the decisions be made about who should get access to care? And should the standard of care change to reflect that care will change under such circumstances? And so the National Academies convened a multidisciplinary panel of clinicians and ethicists, public health lawyers, and others to address this question. Next slide. And we essentially defined crisis standards of care as a substantial change in usual healthcare operations made necessary by a pervasive emergency. And rather than get into the nuanced language of the definitions, what I want to share with you are the key elements of the framework. The first, as depicted on this slide, and as developed by my colleague John Hick from Hennepin County, Minnesota, Minneapolis, Minnesota, really focused on a cascading array of steps that can be taken and implemented within this framework. The importance of conservation, of substitution, of adaptation. You've heard all these elements now in the context of the COVID-19 response, particularly with regards to personal protective equipment. The recognition that at some point we might have to reuse, or in the worst of worst case scenario, have to reallocate scarce resources, particularly life-saving resources, as Don has just alluded to with regards to mechanical ventilation. Next slide. So we developed this systems framework, and I could spend an hour talking just about the Lincoln Memorial. Yes, this is the Lincoln Memorial. Larry Gostin asked me to put on one piece of paper this articulated systems framework that we developed for our 2012 report. And it took a bike ride down the Potomac River and standing in front of the Lincoln Memorial to see it all come together. So let me highlight for you the fact that the key components of this framework are the basis on ethical considerations and the rule of law. Those represent the absolute foundation for crisis standards of care planning and implementation. And then there are a series of steps that you see that are in very purposeful placement. The first is provider engagement. You cannot talk about implementation of scarce resource allocation decision-making without getting doctors and nurses and others who are in the trenches at the bedside making and helping to make those decisions. And then almost equally important is community engagement, and where we will talk perhaps later in the hour about equity and some of the inequities that we're seeing with regards to some of the plans that are coming forward. It's critically important, as we recognized a decade ago, that the community must be involved in these discussions. The community has values that it wants to transmit to us, the all-knowing healthcare providers, and it's really important to hear what those values are and hear what those intentions are. And then there are a series of other steps. The one that I would point out to you being critically important is performance improvement. And I think that maybe that may not be the language that IHI uses, but it's the notion that we need to be deft and capable of making mid-course corrections based on evidence. And of course, in a novel emerging infection like COVID-19, we're only learning as we're going now. And we're only learning, for example, that there are certain risk factors that are beginning to rise to the fore. And so we should make those changes based on what we learn about any given event. Next slide, please. So very quickly, let me demonstrate for you a principle that Don, as Don helped with the letter that we wrote for the National Academies about 3 weeks ago now. Let me demonstrate for you the fact that this is really a dynamic phenomenon. So if you will, it's nothing more than supply and demand, where the x-axis is change over time, and the y-axes, are both demand for healthcare services on one hand, and the supply of resources, whatever those resources might be, on the other hand. And as the demand for healthcare services rises and the availability of supplies go down over time, you begin to transition from what we describe as conventional standard of care, what we do every day, to the area under the curve that is either contingency or crisis standards, contingency or crisis care. It's a fundamental change in the way that we deliver healthcare. And you only emerge out the other end when such time as you either have a resupply of resources or a decrease in demand for healthcare services. And last slide, please. So one other way to depict this, again, highlighting the fact that this is a very dynamic process, is that as you move towards the right of this slide, you transition from conventional to contingency or crisis care, and you cross certain thresholds that we described as a resource shortage threshold, and ultimately the resource triage threshold, where you actually have to make allocation decisions. And again, this is somewhat theoretical. I'm describing the framework, but this is a way to think about how the changes that we are all facing in our own healthcare institutions are occurring in real time. And you should note that the farther you move to the right, the greater the risk of morbidity and mortality. And so at the end of the day, those of us who've been engaged in crisis standards of care planning and implementation recognize that we should try never to get into crisis care in the first place. So our goal should be to avoid that at all costs. And we can come back and touch on that point. Let me just show you, included in these resources, but next slide, please. But too detailed to go into now is in the 2013 report that was specifically focused on indicators and triggers. We put in place a number of tables across all of the disciplines: public health, emergency medical services, hospital operations, emergency management, behavioral health, indicators, triggers, and tactics that could be used to help govern decision-making and planning for the transition across those categories of conventional, contingency, and crisis care, and the recognition for how to begin to return towards conventional care. That may seem like it's a little bit early to contemplate now in some communities, but in others, it may be appropriate. And so I would, if you're going to look at all of the material that we've developed over the years, over the 10 years that we've been working on this, if you're going to start anywhere, I think this is a great place to start. These few slides, and I think, Sarah, you can press ahead. There are a couple of examples here. This would be an excellent place for you to begin. So I appreciate the opportunity to share with you some of the work that we've done. Again, this is the 5-minute overview of a framework, but I hope that you will understand that it's a beginning point for this conversation. And I'll come back to the foundational element of ethics and the rule of law. We included in our 2009 report, an ethical framework that was based on ethical norms and ethical processes. And those norms included fairness, the duty to care, the duty to steward resources. We actually highlighted the duty to plan. And unfortunately, we could make the case that we've abrogated our responsibility to plan by having now to put in place hurry-up plans that may not have been as well thought out as we otherwise would have wanted them to be. And the ethical process, of course, I think you would all agree, must focus on transparency and proportionality and consistency, accountability. We are accountable to the patients who we serve, and we need to be fair in the allocation of resources as we deliver them, even under crisis conditions. So let me stop there. Again, I appreciate the opportunity to be a part of this important discussion this morning.
Thanks so much, Dan. So helpful. Oh, boy. And now somebody else who is going to be very helpful as well. So, Chris Kessel, this is an area you've been involved in for a long time, and you're very much in the thick of it where you're located. And Dan has just kind of handed it off to you in a way, focusing on ethical issues, and that's something that's near and dear to your heart. So would love your observations about what do we need to be thinking about with these crisis standards of care. Thank you.
Thank you, Madge, and thank you, Dan. I want to add a shout out to Nikki Lurie and to Dan and to the fact that 10 years ago, we were doing this planning. So I think that's a really important thing for us going forward, to think about this notion of preparedness and what that entails. Not just about the ethical standards, but about all of the preparedness things that would prevent us from having to make some of these wrenching decisions. But having said that, and given the short time and the fact that we want to really get the viewers' questions, I'm not going to take us through an analysis of how philosophers think about these issues, but what I want to do is highlight a few observations and questions in this whole debate that's been going on these last few weeks. Hard to imagine it's only been that long, that people aren't talking about, that have just as much to do with justice and fairness. So the first thing is that bioethics is a basic discipline of the healthcare world. And most medical education and most sort of thoughtful approaches to how do we train our healthcare workforce have to include the ability to at least understand the basic language of how we talk about values in healthcare. Because when we don't do that, we're going to inevitably see these conflicts, sometimes between different cultural points of view, sometimes between actual crisis standards like this. And in all of those situations, people feel moral distress, and the term moral injury has even occurred. One of the ways to avoid that is just what Dan said, to make ethics visible, to make, if there's disagreements, allow and celebrate those disagreements, give people the space and the language to talk with each other about it. But then, just like everything else in healthcare, at the end of the day, you have to make a decision. And not making a decision is the same as making a decision. So people need to come together and are more likely to be able to do that if there's an opportunity for real understanding and discourse about the issues. So that's the first point. The second point is that our consciousness of this notion of rationing in this country, it becomes very political and very controversial anytime we think we have to ration anything. But as Dan Berwick's point at the beginning, we've been rationing healthcare in this country forever, for decades. And we ration by ability to pay, we ration by access to care, we ration often by quality of care that is kind of invisible, except when we look at the disparities and the outcomes of it. So we need to, I think, include, as we think about rationing, this notion of allocation and how we make allocation decisions. The second point is, even in this crisis, I've been talking a lot with colleagues in New York and working with some of them. Even in this crisis, ventilators are not the greatest shortage. And the greatest shortage is tests. We are rationing tests. Who gets allowed to be tested is a decision that's being made almost randomly in different states and different municipalities. That's a rationing decision. We're rationing, most importantly, and this is what my New York colleagues tell me, most importantly, people. We just don't have enough people who have the skills to take care of all of the people who need care. So in the intensive care context, which we're most familiar with, that translates into, instead of one nurse per one patient or per two patients, we have one nurse per 8 patients or 10 patients who are critically ill. How do you decide who gets the attention of that nurse? How does the nurse decide how to allocate his or her attention? Those two are decisions that need some guidance and that have ethical dimensions. And then the other example, which I think is really vivid and frightening, is that we're allocating by intensity of care. That is to say that the people who are at the greatest risk are in nursing homes. And in nursing homes, staff are leaving. I just read this morning's paper about a nursing home where, because of staff leaving, there are only 2 people left to take care of 100 people, and scores of people, literally 60 deaths occurring within a few days. So we're not paying attention to that as an issue of allocation and justice. But if we really thought about how do we allocate the precious resource of our workforce, then I think we might even have a broader framework for, I love this Lincoln Memorial slide, for how we really think very proactively about how do we allocate staff and how do we support staff who do this. So the last thing I want to say is has to do with this controversy about disadvantaged groups. People with disabilities and age are the two categories that I think have gotten the greatest attention. And in fact, in many of the approaches to the ventilator allocation issue, people have specifically said we're not using categories of people, we're using prognosis. Sometimes that translates into age, for example. Sometimes it doesn't. And we need to get better at understanding that. But I would just point out to our audience, and then Madge, turn it over to you to open up for discussion, that justice is not always the same thing as fairness. And if we look at fairness, probably the fairest way to allocate ventilators would be a lottery. So it doesn't matter who you are, what your condition is, maybe you're going to die tomorrow anyway, you have an equal chance of getting that ventilator. But justice has a more nuanced characteristic, and it gets to Dan's point about making special efforts to provide care that gives people an equal chance for life or an equal chance for success. And then you have to factor in prognosis, but you may have to factor in some of these other determinative factors that underlie social inequities. We can't correct those with these allocation decisions, but we absolutely need to be mindful of them. So let me stop there and let's open this up for discussion.
Thank you, Chris. I think you were also sort of giving us maybe a real-time lesson in bioethics, which is something you told me that you feel more clinicians and more of us need to more broadly understand and have some training in, which I think is good. So we're starting to get this. I want to turn to, thanks, Chris, for your thoughts. Derek Feely is with us, IHI's president and CEO, and he is going to sort of play the role right now of sort of some of what he's heard in this first half hour, and then we will go to questions and comments. Derek, you're on.
Thanks, Madge. I really want to try and approach this from the perspective of what should people do. So now they've heard what Dan and Chris have had to say. They have Don's initial reflections, and you know, nearly 1,000 people registered for this. They did so, I'm sure, with action in mind. What advice might we give them about what they should do? And so the first thing I would say is take time to reflect and discuss. Go talk to your colleagues about what you've heard today. Don't worry alone about this. If you're facing these kind of decisions daily, make space to reflect and discuss. And I really appreciated Chris's point, and I think it's particularly apt for the leaders who are tuned in is to give people space and language that they can use to have those reflections. Second thing I would ask people to do, and Dan invited this, was lean in and improve the standards. You know, the frameworks and standards are most needed, most valuable in times of crisis. This is the time where we need standards and frameworks more than any other time in our professional lives. There are reference points, there are a light in the darkness that we can refer to as and when we need them, and they're never perfect. So on the basis of those reflections and discussions that you're going to have, lean in and interpret and improve in your systems. I really appreciated Dan's point also about this as a systems approach. So there are social and, as Chris said, ethical and clinical dimensions to this. These are not solely clinical decisions. And so I appeal to our audience to think through a systems mindset about these kind of issues. And then finally, I do want to come back to the point about have equity in mind, and the points that have been made thus far about how fairness is not justice. Equity of access is not equity of outcome in these circumstances. And let's have these things uppermost in our mind as we're having these difficult conversations. So those are some of the things I've heard, Madge, and an invitation to the audience to take some of those things and reflect and act on them in their contexts and environments.
Thanks, Derek. Okay, well, a lot to think about. And I did throw in the question about wondering whether this was the first time for those of you joining us today that you've ever been part of a discussion on this matter, which is telling unto itself. And if it is the first time, and already starts to suggest a to-do in terms of during this pandemic and finding out where these conversations take place in your own healthcare organization. All right, we are going to now turn to your questions in the chat. Again, please chat to all participants. I think we're going to go to Dan for this. And Dan, if you didn't see this one, I'll just paraphrase. Given all the work that you have described that's gone on for the past decade, a listener is wondering, why does it seem as though it's not better integrated across the country and sort of been translated into practices? And if it has been, we're just not aware of it. Speak to that as well.
Yeah, thanks. Thanks for the question. And I think that's a very apt observation. I think you're right. And the way I would frame the answer is that, the few of us who spent our careers focused on disaster planning, preparedness, and response recognize that we do so that others don't have to be honest with you. It's like the firefighters, who are willing to rush into the burning building so others don't have to. And there's a myth, I think, that has been perpetuated, I should say, across time, which is that disasters happen to someone else somewhere else. And so it is easy, particularly in the fractured, challenging healthcare environment that we work in and day out, to put this off. And even primarily from a financial perspective, disaster planning, preparedness, and response costs money, as we're learning now, right? With regards to the shortages that Chris pointed out, including tests and PPE and personnel and so on. So I think that we have, we've skirted those responsibilities, and it's the unfortunate legacy of a decade of increasing sort of dissonance within our healthcare institutions, and a just-in-time philosophy that squeezes the little profit that it can squeeze out and leaves aside some of the heavier, more difficult planning efforts like disaster planning to the sidelines.
Dan, if I could just hold you there for a moment for another question or comment. Somebody wrote in the chat that an organization, a hospital perhaps, is reaching out to the disabilities community for some guidance in terms of how they should approach this issue. And that, apart from responding to that in particular as a good practice, what has been the degree of public engagement? It's noted there as a principle, and yet I dare say here in Massachusetts, when the governor started talking about guidelines, it really kind of whacked people upside the head. It startled. I'm not sure people understood, and so what public tends to get involved in this?
Yeah, so actually, the interesting thing is that in 2012, when we convened for our deep analysis of this entire area of exploration and development of the systems framework, it's when we articulated the importance of community engagement. And in the 2012 report, we actually developed a community engagement toolkit. I think we were the first to develop such a capability. And to be honest with you, we ran it in Massachusetts, and we did it in 2 sites. We did it in Boston, and I know some of you on this call are sitting in Boston or in the environs right now. Everyone seems to have 2 PhDs. It's like 2 PhDs per capita, and very educated, very erudite, very knowledgeable community. And we ran this community toolkit in Boston, and then we took it up the road to Lawrence, Massachusetts, which for the rest of the country who may not know, Lawrence was the mainstay of our textile industry. It was actually where fleece, everyone wears the fleece sweaters and so on, was first produced. It is now a terribly economically disadvantaged, mostly poor, demographic, mostly Latino. And we asked the same questions that we did of the PhDs in Boston. And believe me, the community in Lawrence got these issues as clearly, if not clearer, than the folks, down the road in Boston. And so it highlighted for us the recognition that the public really can engage and does have a voice in these matters. To answer the question now more directly, after our effort, there were a number of efforts that were put in place. And I should say, actually, preceding our effort, there was excellent work done in Seattle-King County by Meredith Lee Vollmer on allocation of scarce resources that preceded our work. There was also work that was being done up in the Minnesota, particularly Minneapolis region, around scarce resource allocation. And then after the fact, an excellent effort that was conducted across the state of Maryland and also in the state of Illinois. I was involved in the effort in Illinois. But unfortunately, these were really the exceptions rather than the rule in terms of meeting those key recommendations that I laid out in those steps that formulate the steps on the Lincoln Memorial diagram. So the fact is that many more states did not engage in these conversations. And I think that that's why we're seeing such a disarray and such a spectrum of offerings with regards to the crisis standards of care plans that are being put forth now. And I would make one last point, and that is that, the plans are only as good as the planning effort that goes into it. And it's the conversations that are the most important, and it's the engagement that's the most important. So I would point back to the fact that if this is the first time, and I'm looking at the chat, if this is the first time to answer Madge's question that you're thinking about these issues, well, now's a great time to start. This is a great place to start. And of course, these resources hopefully will be of use to you in taking these conversations forward.
Thanks, Dan. I want to turn to Chris Castle, and certainly, Chris, if you've seen anything in the chat you want to address, but this one I thought might be appropriate for you. What about support, emotional support for staff in some way, also kind of in the thick of making all kinds of decisions and often on the spot? And if you can draw on any experience that you're familiar with, that would be great. I will point out that I guess the guidelines in many ways are designed to take some of this off the shoulders of staff, but that does not mean people are not making any more decisions or in some way don't feel the effects of things. Chris?
That's right, Madge. I would point out that most of the crisis standards of care that are being put into place right now, particularly focused on ventilator allocation, specifically have some kind of committee, triage committee or something like that, so that the physician treating the patient doesn't have to be the one making the decision. Both because it's felt that that would be, quote, a conflict of interest if you're looking at a fair allocation strategy, but also the emotional hurt that might occur to a person having in that situation, because I think, you know, people do care about the patients they're taking care of. As much as we want to talk about population health and best outcomes for the most people, when you're the doctor or the nurse who's right there, you can't help but become emotionally involved in that person's outcomes. So, so the idea is to have this triage committee, and I think fundamentally it's a sound notion. It does have a couple of flaws and actually some opportunities for research, I think. One of the flaws is just that it takes time. And often in these settings, particularly in the emergency department, these decisions need to be made really quickly. And you're talking to family members who can't be there with the patient and trying to have some remote conversations with them about palliative care choices and end-of-life choices. And at the same time, you're trying to make this decision and get this committee together. So, you know, it's conceptually a good idea. I think operationally, it sometimes is hard to get it to actually work very smoothly. The other thing is that I'm not sure we know whether having a committee make the decision really reduces the emotional distress for the caregiver, for the clinician. I think it's a reasonable hypothesis, but I don't think it's been studied or tested. So I think this might be, if we get into these kinds of situations, I hope some people will be doing the studies that will help this. I want to point out one other thing that just related to this general issue of clinician well-being is that I had the honor of chairing a committee for the National Academy of Medicine on clinician well-being that was released just last fall, late October, excuse me, just before this pandemic really became visible and before it hit us. So already we were in a situation of significant burnout and problems with moral distress, as well as overwork and needing to rethink our systems of work for our workforce. So this should just be an opportunity for us to really pay attention to those issues and up our game in general about being compassionate to the clinicians who are doing this kind of care. So I think most people who are in charge of big systems of care are now recognizing that, but we need a lot more, certainly the public support, you know, the applause at 7 o'clock at night that the healthcare providers are getting is helpful. But I think what is most helpful is what Derek emphasized, which is allowing people the space. It doesn't have to be an hour sit-down meeting because nobody has time for that, but just the space and the ability to say, wow, how did that feel to you? Or how are you doing? Or do you really understand why they made that decision? Or just open it up. Don't make it taboo to talk about those things, because that's where you end up with the real distress and often misunderstandings about why things are done and how things turn out.
Okay, thanks, Chris. Let me turn to you, Don Berwick, for a question. In different ways in the chat, it seems to me people are also talking about historical mistrust of the medical system, the healthcare system, based on past and maybe not far away enough, issues that have come up for Black people, people of color, other marginalized communities in our society, disabled as well. And I wonder what you think kind of bridges this at this point in time. And Derek, of course, is telling us suggesting that we need to think about what are we going to do. But that mistrust in this kind of circumstance, when you are not anywhere near the bedside and can advocate, and you've got to just sort of work through whatever they're doing in the hospital, if that's where you have a loved one, I mean, to me, that can certainly contribute to more mistrust and not understanding. Also, access to clinical trials right now. Who gets to go in and not, and what are the exclusion criteria and inclusion? So I can see a lot of very, very heated areas here. Don?
Heated indeed, Madge, and maybe we can ask Chris and Dan to dig in a little more. I found Dan's distinction between fairness and justice that Derek picked up on really eye-opening. I'd never quite thought of that. I probably haven't read enough to have thought of it. But
Don, can you come a little closer to the?
Yeah,
there you go.
Sure.
Thanks.
I was mentioning Dan's distinction between fairness and justice and how much that caught my mind and my eye. I'd not heard it quite stated that way. So to put a point on your question, Madge, I think let's talk about race. We are in a country with a dreadful history of racism. It's still with us in many forms. Several of the questioners have asked about prisons, incarcerated people who are extremely at risk in this era. So as Chris and Dan have thought about crisis standards and ethics, in an environment where the historical injustice is so big, how should we factor that into our thinking about, well, resource allocation and special efforts to redress the disadvantage that let's start with African Americans, although we could name other groups are in. I think it's very tough, and I'm not claiming anyone has an answer, but the question sure has arisen, and I wonder if you two could opine a little bit about that. Maybe the way to say it is, should we use a lens of justice to make allocation decisions that redress the injustice consciously in a crisis or not?
Yeah, so I'll start, but first start by pointing out, I think it was Chris that made that excellent distinction between fairness and justice. Just to be totally honest, and I too had not quite heard it that way, and I think it's an excellent distillation of the issues. I'll give you my answer, Don, from an emergency manager's perspective, from someone who has responsibility from an operations, level vantage point. And what I will say is that, and it speaks to the frailties of this entire response thus far, and that is that in the absence of data, it's awfully hard to make the right decision. And I think you and your colleagues have harped on that over the course of all the excellent work that IHI has done, and have brought us as a healthcare community to recognize the importance of making evidence-based decisions and using data to help make those decisions fairly and to improve healthcare delivery. Well, the same holds true in these disaster events. And so what I would say is that in the absence of data, and really we have been flying mostly blind, it's hard for us to make those decisions. So I have looked at heat maps, for example, in New York City, where the Bronx, Queens, and Brooklyn show up in dark shades of blue, where Manhattan shows up pretty light. And that is pretty telling with regards to the lack of equity, and there's a demographic factor that fits in there. And I think that one way potentially to begin to address these resource allocation decisions is to recognize that what we could do is preferentially support those communities with a pro rata delivery of resources because we can already anticipate that they're going to have higher requirements. Now, that's not an ideal solution. That's a on the fly, make a decision, in the heat of the moment. But I think that may be at least a step towards addressing some of those inequities. And yet, in order to do that, we need to invest in the real-time data acquisition and sharing systems that would allow us to do that.
So let me just add, Dan, to that, I completely agree with you about the data and flying blind. And once you had that data, though, and Dan knows this very well, Don knows this very well, that you have to have a system if you were going to have a kind of a justice-based framework that would be restorative, that would address some of the inequities. The first thing you have to do is actually be able to implement that, which would mean having a system that would say, in the example I gave of the nursing homes, that most of the people who are in nursing homes now are people who are poor and they're on Medicaid. It's a huge part of our frayed safety net system. So you'd have to be able to say, we're going to allocate these many nurses to long-term care and these many to critical care and make that decision. We don't have a healthcare system that allows us to do this. As you know very well, there are other countries that do. They have a unitary system. They're able to allocate both technology resources and things like PPE, as well as people, and allow them to go where they're most needed. And then if you had that capability, then you would be able to ask then the really important question, how do you define where they're most needed? And then I think that's when I think we really should have this discussion that, and getting back to Dan's earlier point, that would then bring in these disadvantaged communities as part of the deliberative decision making and have that be sort of a process that would help us plan going forward. But in the absence of that, because I'm mindful of Derek's point about, well, what do people actually do? Here we are in the United States in our fragmented and divided nation. I think it's really tough to ask people on the spot in a single microsystem like an ICU or an emergency department to make those restorative or redistributive decisions one by one themselves. That's a very hard thing to do. I think the best you can hope for is to have those hospitals and community health centers that really are part of their community already have that built in to what their approaches are. I know that's true for many of the safety net hospitals. But the other thing is that just to have people be mindful of it, so at least you can overcome implicit bias. If people are not even mindful of it, then those kinds of things slip in. So probably the awareness issue, which was the number one recommendation from the other National Academy report on looking at social determinants of health in the perspective of the healthcare system. The first thing they recommended was awareness. So I think that's a really important part.
Thanks, Chris. Derek, I want to bring you in here. And certainly if there's something you're spotting in the chat or anything you've heard you want to speak to, do. The question I thought maybe I'd put to you is several comments that have to do with staff. What Chris was just talking about, the burden of also staff having to make these individual decisions. Sometimes that's what it feels like if you don't have some guidelines. Many people are concerned about burnout, PTSD, moral injury, things that we also are thinking a lot about at IHI with Joy in Work, and you're trying to continue to evolve how to think about that during COVID. What are some of your thoughts right now in terms of even really being sure that we're starting this process of paying attention to staff in this environment moving forward?
So, Madge, I think this is another example of something where a framework will be helpful to people. Otherwise, I think we risk just well-meaning activity. And so, as you say, at IHI, we have a framework for what we call joy in work. And joy in work might feel like a bit of a step too far for people right now. I understand that. I understand that first and foremost, our frontline healthcare workers need PPE, and they need to feel physically safe. But I suspect that some of the longer term implications and damage of this will be to people's feelings around psychological safety and burnout. And so I would encourage people just to refer to the IHI framework. And it starts, and there's been some iterations in the chat about this. It starts with a very simple question, which is to ask our colleagues what matters to them, what's important to them at this time, and then to try and remove some of the barriers to continued connection to meaning and purpose from their paths. So, yeah, that would be my best advice. Find a framework that's helpful. All frameworks are flawed. Some are useful, but find one that you think is useful, and begin conversations with your colleagues with that question around. Let's talk about what really matters to you just now. Let's see if we can fix some of the things that are getting in the way of you bringing your best self to work.
Well, thanks, Derek. And there are so many interesting and important comments and questions. I hate to be the one to tell everybody we're going to have to start to wrap up on every one of these programs. We say, oh, let's make it an hour and a half, but we are very cognizant of people's time. And I want to say that throughout these virtual learning hours, we continue to reconnect with those we know, and new people we're meeting, and we're going to surely nurture these new connections and make sure that we keep track of what's going to happen in these spaces, so that we're not just in one and done virtual learning hours, but this is going to carry on in our work, and certainly let us know what you are understanding. So Dan Hanfling, I do hope we'll hear sort of how even the National Academy of Medicine kind of continues to evolve these issues, and we'll look for interesting models out there. We did see some things in the chat already about people trying to struggle and take these crisis standards and make them more like it feels perhaps in the year 2020. Don Berwick, we didn't really have time to get into, if we look at this globally, we also have a lot of inequity that we must contend with. And I do want to acknowledge the comments in the chat that referenced the moral and difficulty decisions for staff who felt that it was just too unsafe to work. And we know there's tremendous pressure on clinicians during a pandemic of the sort. And so I just want to acknowledge that point. It's an important one and something else we hope we will continue to look at. So I want to remind you that virtual learning hours are one of the free benefits of IHI's new membership program. And we have 4 more of these programs, and who knows what we'll do after that, but we'll keep thinking, and you can keep telling us ideas. A big thank you to Don and Derek, Dan and Chris, and the wonderful audience and the team supporting this program today behind the scenes. The archived edition of it will be posted to IHI.org and no later than Monday, but we're so far been meeting an amazing deadline of even getting it up there before close of business today. We're going to be back next Friday at 10 a.m. Eastern Time, and we're going to look at another big issue, the dynamic relationship between QI, epidemiology, and medical treatment that has surfaced for real in COVID-19. Details soon on IHI.org. In the meantime, we really wish you all the best. It's my honor to moderate these programs for the Institute for Healthcare Improvement. I'm Madge Kaplan. Have a good weekend.